Okay, hi everyone. Welcome to this month's Doctor Talks event. We'll get started with introductions, a case study, and then we'll move on to our participant Q&A session, where if you have any questions for our physician, please leave them either in chat or you can feel free to turn on your camera and ask the questions yourself. So yeah, let's just get started with introductions. Would you like to go ahead?
I'll go ahead. My name is Dr. Anokwute. I'm the neurosurgery resident here at Indiana University School of Medicine. I'm a fourth-year resident. I'm not sure what the group consists of, if you are all undergrad students or medical students, but I kind of tailored this talk so that it would be pretty broad. And I included some things in here as well to allow for kind of discussion later on, and also kind of show you guys the pathway to get to where I am right now. I'll go ahead and let you all introduce yourselves as well, but this was a pretty interactive talk, so please, I love questions. Ask as many questions as you can, and we'll have a lot of fun doing this.
Yeah, sounds great. And for everyone here, hi, my name is Isabel. I'm the CEO and co-founder of Generation Med. We're an organization of mostly like undergraduate students who are trying to get into med school. So thank you so much for your time today as well.
Thanks for having me. All right. I'm going to go ahead and share my screen here. Give me 1 second. There we go. It should. All right. Let's see if it works now. There we go. Perfect. All right. Can everybody see that? I hope that's a yes. Excellent. So like I said, my name is Dr. Anokwute. I'm the neurosurgeon here talking with you all today. The talk that I'm giving today is pretty general, just to kind of give you guys an overview of what neurosurgery is about. It's titled The Bread and Butter of Neurosurgery. So we're going to go over some cases as well that encompass what I normally do on a daily basis and the typical things that I see as a neurosurgeon when I'm here in the hospital. Like I said, I'm a PGY4 neurosurgery resident, and we'll go over the steps to get to neurosurgery as well, and what that means as a fourth-year resident. I have no disclosures. Nobody's funding this talk. So a few quotes here. These are some of the things that kind of stimulate my mind whenever I'm doing an operation or whenever I'm talking to a patient or interacting with a patient. One of those is by one of the fathers of neurosurgery, Wilder Penfield. Dr. Penfield stated that the brain is the organ of destiny, and it holds within its humming mechanism secrets that will determine the future of the human race. Now, he was a great neurosurgeon, great physician, and he's somebody that we owe a lot of the information that we know today in neurosurgery to. Another person that is another father in the field of neurosurgery is Dr. Harvey Cushing. Dr. Cushing is very well known for his work on pituitary adenomas that led to Cushing's disease. And he stated, I would like to see the day when somebody would be appointed surgeon somewhere who had no hands, for the operative part is the least part of the work. And that's absolutely true. Neurosurgery itself involves using your hands in the operating room. But most of what we do is actually the decision factors that come into play to make the decisions of taking someone to the operating room. And that's done as the majority of my job on a day-to-day basis, is looking at patients and determining who needs surgery, who doesn't need surgery, and who we can take care of with surgery that are going to do well from the surgery standpoint. So when you think about those two things, then, and you're excited about those two things, then you're definitely somebody who wants to do neurosurgery. So what is neurosurgery? So neurosurgery is a surgical treatment of neurological disorders of the brain and the spine. These involve tumors of the brain and the spine, such as metastatic and primary brain tumors and spine tumors. It involves vascular pathology, and those include aneurysms, which are weaknesses in the blood vessel wall that lead to an outpouching of that blood vessel wall. These can rupture and cause significant morbidity and mortality to our patients. Arteriovenous malformations and arteriovenous fistulas. Now, arteriovenous malformations have a nidus where there's an abnormal connection between an artery and a vein without any capillary structure around it. And arteriovenous fistulas is just a direct connection between the artery and the vein without a nidus at times. We also treat peripheral nerve disease. So if you've ever heard of somebody with carpal tunnel syndrome, that's something that neurosurgeons treat pretty regularly. In fact, I've done several cases in the past few weeks on this. These are peripheral nerve entrapments of the ulnar and the median nerve, carpal tunnel syndrome being an entrapment of the median nerve itself at the wrist. Cubital tunnel syndrome is an ulnar nerve entrapment at the elbow. And you also have peripheral nerve sheath tumors, schwannomas, nerve transfers that we do for patients who have injury to the brachial plexus themselves. These are pretty cool surgeries actually to do. I've done a few of these in pediatric patients and they've done very well. We also do functional neurosurgery, and this is an evolving field in neurosurgery. It involves the treatment of epilepsy, so patients who have seizures, deep brain stimulation for disorders like Parkinson's disease, where we place electrodes into the brain itself to help stimulate those areas and change the pathomechanics of those neurons to allow for improved function in our patients. And we also are now venturing into the field of psychiatric disorders such as depression and other psychiatric disorders as well. They can also be treated with neurosurgery. Now, this is an evolving part of the field and not something that's done routinely, but these are the future directions that young people like yourselves could potentially go into. My favorite part is the spine. I'm very much interested in spinal disorders, and that's something that I look forward to doing. We treat degenerative spine in our elderly population and populations that have significant damage to their spine themselves over time. We perform minimally invasive spine surgeries in a way to allow for patients to get back to work and get back to their lives as quickly as possible. And we also treat deformity spine patients, such as patients who have scoliosis. We do spinal oncology surgeries, which involves taking out tumors from the spine itself or from around the spine. And one of the things that I've done in my PGY2 and PGY3 years, postgraduate years, which we'll talk about, involves pediatric spine as well, which is quite a bit of scoliosis, but also quite a bit of trauma as well. And then there's pediatric neurosurgery. So pediatric neurosurgery is a very fun field to go into if you are somebody who wants to basically do it all. Children are fantastic patients. They do very well from the surgical standpoint, but they can also be very complicated patients in that they're also very, very small to take care of. Some of the presentations that they'll come with is called hydrocephalus, which is water on the brain, a fluid on the brain where the ventricular structures, which are the structures within the brain itself that hold the spinal fluid, become enlarged because either overproduction, lack of drainage, or a change in the mechanics of absorption of that fluid. And so we have to redirect that. And that's one of the most common surgeries for pediatric patients. So now that we've gone over just neurosurgery in general, why don't we jump into what this field, how to get to this point and how to go ahead and get to becoming a neurosurgeon. And again, feel free to stop me, ask me questions, and I'll try to check the chat periodically if I'm able to, but if anybody else is able to, or just jump in and unmute yourself and ask a question, I'll be happy to answer it, okay? So pathways to neurosurgery. So you all are in undergrad, it seems like. So determine your interests early. So determine if you want to go to medical school, determine if you want to be a doctor, determine if you want to be a surgeon. There's a big difference, being a doctor and being a surgeon. Being a surgeon means that you're doing surgeries and take care of patients in the operating room and resecting or adding things to the patient's body habitus to help provide care for that patient. Being a doctor means, managing patients medically, which means being in the hospital or outside the hospital in your clinic, imagine their ailments with medications, manage your ailments with care, discussing with the patient, and just interacting with your patients for long periods of time. And I don't know about you guys, but I still talk to my pediatrician. And I have a long relationship with her, and somebody that I followed through all the way till I was an adult, and she had to kick me out of her practice because she's like, "You're too old." So that's very different from what a surgeon is. A surgeon is somebody who will come in and see a patient for a short period of time, determine what they need, what needs to be done for that patient, whether it's a surgery itself or conservative management without any surgery, and then perform that surgery and have the patient back to what they were doing before or back to their livelihood as soon as possible. So you don't have that long standing relationship that medical physicians have with their patients. So you have to determine if that's something that you are willing to do. Now, the next thing, which I'm sure you guys are all great at, is studying, right? So form your study habits early. Learn how to study because it doesn't stop. I was just at the coffee shop today studying. I'm working on papers and research. Perform well in your exams. You're going to take tons of exams to get to this point. I mean, your MCAT, your board score, your board exams, USMLEs, which we'll talk about in a little bit, and then your boards when you are a physician as well. So lots of exams coming your way. And if you form these study habits early and you learn how to study well, then you're going to do well on these exams. Find a mentor and shadow, which is something that you guys are already doing right now. A mentor is very, very critical to becoming a neurosurgeon. And a mentor is very critical to being successful in anything that you do. At least I think that that's the case. I found my mentor very early on in medical school when I was a first-year medical student, and his name is Dr. Mitesh Shah, and I've known him for years now, and he's one of my staff here. Mentors will guide you through the process. They'll tell you their mistakes so you don't do them, and they'll show you, what the next steps are for you to do. Do research. Now, in undergrad, you don't need to do as much research, but in medical school, you kind of need to get into the research for neurosurgery. So finding a mentor will help you get into that point. And then when you get into residency, you're going to have to do some research as well. And then I don't think there are any medical students on here, but if you're a medical student, you have to learn how to schedule some of your rotations, which are the courses that you take in your third and your fourth year, to help maximize your matching into neurosurgery and also maximize the interviews that you get for residency. Check in to see if there are any questions. I don't see any. So applying to neurosurgery, this is something you guys don't have to worry about. Like I said, I tailored this talk just to see if there were going to be medical students as well here. But when you get to the point of being in medical school, you have to have the research on your application. There are away rotations, which is where you leave your own institution and go elsewhere to experience neurosurgery at different institutions and see if you're a good fit for that program and if they're a good fit for you, because that's where you spend the majority of your time as a resident. Your boards, which are your USMLEs, which you guys fortunately don't have to worry about for a very, very long period. Networking is very important, and that's something that you can start doing right now, which is what we're doing today. And then don't worry about the interview season and interviews. But I will say this for interviews and interview season, to get into medical school, practice your interviews. So one of the biggest things is sit down with somebody and go over the interview with them so that you can be able to answer the questions that that people will pose to you in a good amount of time, and then also in a way that makes you the best applicant possible for that medical school. So let's jump into neurosurgery residency. So now you've gone through undergrad and you're like, yes, this is it for me. You've gone through med school. You're like, all right, I'm definitely doing this. And you're applying to neurosurgery residency and you're wondering in your head, what am I signing myself up for? Well, it's a long road. It's the longest residency of all the different specialties that you can go into. It takes 7 years to do a neurosurgery residency. I'm in year 4. And the way my program is structured is that in our intern year, which is your postgraduate year 1, You rotate through the neurosurgery department, the neurocritical care, the ICU department, neuroradiology, and neuropathology, just to get a broad overview of everything neuro. You learn to take care of patients in the ICU and the operating room, learn about the tumors that you're taking out and see what the pathologist sees in them, and then also learn about the image findings that you need to know as a neurosurgeon before you take somebody to the operating room. Now, your second to your fourth year in neurosurgery is spent in neurosurgery here. So this means that you're in the OR every day that you're in the hospital, you're operating, or you're in clinic taking care of our patients and seeing our post-ops. In your fifth year, you typically take a research year, or you find something that will help your career in whatever that you choose to go into. In your sixth year, we call this the chief year. This is where you're in charge of the major academic center. You're the one that all the residents report to. The staff call you to find out about their patients and want to know everything from you. And so you run the entire service and you're in charge of that, of all that. So if you ever watch Grey's Anatomy and they're like, oh, I'm the chief. Well, you are the chief. You're running everything. Oops. And then in your seventh year, you can do an unfolded fellowship. So that fellowship can involve spine here, where you learn more about the spine and how to operate on the spine. Skull-based surgery, where you're taking out tumors via complicated skull-based approaches. Vascular neurosurgery, where you're both doing endovascular, which is a minimally invasive approach, with fluoroscopy and microcatheters to get to the brain and treat aneurysms and other vascular pathology, but also doing open vascular surgery, where you are actually doing cranies to take vascular malformations out. And then there's also neuro-oncology, where you take care of everything tumor. So now we're going to jump into some cases. So I'm going to pause here. And does anybody have any questions about neurosurgery, pathway to get into neurosurgery, and what you need to do to kind of get yourself on that path? All right. So let's jump into some cases. So you have first case here. And please jump in and answer questions or ask questions, and I will just keep going through it. So there's a 21-year-old male there. You get a call from the ER doctors. A 21-year-old guy here. He's got shot in the head. We see a hole in the left orbit, and we see a hole in the left side of the skull. They tell you the exam is what they call a GCS-7T. Now, what does all that mean? So you're on call, you're the intern, it's your first day of residency, and you're like, oh my God, somebody got shot in the head. What should I do? Well, slow down. You think about the clinical question that's being posed to you, and you go from there. So they go see the patient is the first thing that you do to gather as much information as possible. You go see the patient, and sure enough, there's a hole in their head. And you're like, all right, what do we do now? The next thing you do is do a physical examination. This is how all questions will be posed to you as you go through case studies in medical school and in residency. And so you go to your physical examination. The physical examination for neuro is very different from the physical examination for other things. So neuro-wise, we look at something called the Glasgow Coma Scale, GCS, and that gives you a general overview of the functionality of the patient that you're seeing. So we look at the eye-opening response, and that grade is from 1-4, and you're looking at whether they're opening their eyes to pain, they're opening their eyes to voice, or opening their eyes to sound, or they're not opening their eyes at all. The highest score that you can get on the Glasgow Coma Scale is a 15, and the lowest score you can get is a 3. So patients will range from GCS 3, which is not good, to GCS 15, which is very good. You look at their verbal response, and the verbal response ranges from 1 to 5, or T to 5 is what I would say. A T means that the patient's intubated. There's something in there. There's a endotracheal tube in there to help the patient breathe, and they're hooked up to a ventilator. And the verbal response from any patient can be that they're completely oriented and answer your questions, or as bad as they're intubated or not talking at all. And then the motor response looks at how they move, right? So, and this ranges from 1 to 6. So they're either moving to your command, you tell them to lift their arm up, they lift their arm up, wiggle their toes, they wiggle their toes, which means they're able to process that information like you and I would, or they're not doing anything, which is basically paralyzed. Localizing means that the patient's not awake enough to tell you, or the patient's not awake enough to do the command that you tell them to. But if you were to go and pinch them somewhere or pinch them and they're trapped, then their arm will cross over midline to come after where that noxious stimulus is. And so if they're doing that, then that's pretty salvageable. And so when this patient was seen, they were declared a GCS 7T. So 7T means that their eyes were closed, they were localizing on examination, and they were intubated. Now, this patient is localizing on the left side because what part of the brain controls which side of the body? So if you're moving your left side, which part of your brain is controlling that? Anybody know? Oh, let's see. The right side, that's right. The right side's controlling it. So if the patient's localized on the left, it means that the right side is controlling that, but they're not doing anything on their right, which means that there's something wrong with the left side of their brain. So you don't even need to do anything else, and you kind of figure out what the pathology is and where that is located, and you know what the next step is. And the next step is going to be what? What do you want to do next? So you can get an MRI of the brain. In this case, I wouldn't get an MRI of the brain. Does anybody know why?
I'm gonna assume that because like for MRI, you need to go through like a whole procedure and it might be dangerous to get an MRI at this stage.
That's very true. That's one reason. There's another bigger reason why. Yeah, patient could bleed out, consciousness. That's another reason. But let's say that there's still a bullet there, right? And what are bullets made out of? Metal.
Metal.
Right? And so if you go get an MRI, then that bullet starts bouncing around in the brain, then that's no good. So you want to get another sort of image, and that is a CT scan. The CT scan itself, correct, Ellie, the CT scan itself has no interaction with the metal, won't pull it one way or the other. And so if you don't know if the bullet fragment's still there, then a CT is the best way to go. So let's take a look at this CT here. Give me 1 second. I'm going to pause the share here. All right, let's do this. Share screen. Okay. So let's go through this really quickly here. So what do you guys see in the CT?
The white mass is getting larger.
Yeah. So that's part of it. So there are a couple of things. So we'll go over it one more time. So right here, so let's just go over what a CT is. So the white that you see here, this is the skull, right? So CT of the brain. And when you're shadowing a physician and they show you a scan, you have to describe it in certain ways. One is, what kind of scan is it? It's a CT of the brain. Is there contrast or no contrast? We're not going to go into that. What kind of cuts are these? So these are axial cuts. And so they're axial going through the head like this, right? Coronal cut, sagittal cuts will go like this, and coronal cuts will go basically in front to the back. So the white that you see here is skull, right? That's the bone. right here, what you see in this gray miasma there, that's the brain. You can't really differentiate the different structures in the brain on a CT. You can, if you have a really good CT, you can tell where the white matter tracts are. You can tell where the gray matter is going to be sitting on the cortex. You can see certain distinctions in the gray-white differentiation that you see there. And you see these black holes here. Those are the ventricles. Those are the fluid-filled structures in the brain. So water itself is black on a CT. Air is black on a CT, bone is pretty dense, so it comes out pretty white, and then your brain is mixed with water, so you kind of have this grayish distribution that you see here, mixed in with some normal structure. Now, you compare one side of the brain to the other side of the brain, and when we look at this side of the brain, we don't see anything there. When we look here, there's something here, right? So that's a bleed. And you can see that it's blood because it's not the same density as the bone. It's not the same density as the brain, but it has a mixed density that is brighter, which because of the density of the blood itself, but there's also some brain tissue in there as well. The other thing you want to look for on CT scans is symmetry. So if I were to draw a line from here all the way back here, you can see that there's a shift to the other side, right? So there's a mass lesion here and it's pushing the brain to the other side in a patient who's relatively very, very young, who has a poor neurological examination. You can also see the exit site coming up here. You can see the bone that's been fractured. So you look at all these things, you see air in the brain itself that shouldn't be there. That's called pneumocephalus. So you look at all these things and then you have to make a decision as what to do next. So who wants to say, all right, nothing to be done here. Let's just sit back and go back to the office and drink a cup of tea. Who wants to say, wow, I see something in there, let's rush him to the operating room? Or who wants to say, let's go do something else and get another scan or something like that? What do you guys want to do?
I think you should be rushed to the OR.
I agree. So this patient was rushed to the OR relatively within 30 minutes of us stopping by to see him. He was rushed to the operating room, and this is his case. We did what we call a decompressive hemicraniectomy, and you can see that we've opened up the skull itself. The bone's completely off. The dura, the tough mother is what it's called in Latin. The dura mater is exposed and cut open in a stellate fashion to allow for the brain itself that's under pressure to herniate outwards. Now you can see that there is a little pumper here, which is continued bleeding from where that bullet went through. You can see that the brain itself is has bruising to the brain itself from the bullet tract, but also there's significant amount of blood around the brain itself. So we do the case, we decompress the patient, get him up to the ICU, place what we call an ICP monitor into the brain to measure the pressures in the head. He goes from not moving his right side and localizing on the left to following commands completely on the left side and having some flicker of movement in his right side as the swelling got better. I'm going to show you what his post-op CT scan looks like because you want to see how much of the brain is decompressed if you did an adequate job and to ensure that there's nothing else that's going on that needs to be addressed. So you always try to get a CT scan after surgery within the first 24 hours. So I'm going to show you one more scan here. I think this is it. No, that's not it. Give me 1 second. Oh, there it is. There we go. It's closed with staples. He's completely decompressed posteriorly. And you can see the ICP monitor coming in here to measure the pressure in his brain. And over time, that bleeding subsided, and he went home to his family. And last time that we saw him was about 6 months ago or so. He's done very well since then. Is just mobilizing with physical therapy to kind of get back to functionality. And yes, this is also an axial CT scan of the brain. Well done. All right, let's go to the next case. Anybody have any questions about that case? So next case, we have a 62-year-old female. She comes into your clinic, super nice lady. She says she has a history of asthma, hypertension, hypothyroidism, and somebody, she had a seizure and got a head CT, which showed left frontal meningioma. She has not had any more seizures because she's on medication called Keppra. You do what we talked about, which is you get the history from the patient. You get a physical examination. The physical examination is that she has no cranial nerve deficits. She's full strength, 5 out of 5 strength in her bilateral upper extremities and her lower extremities. And she's talking to you and she asks you, what do I do next? They got a CT scan and they say I have this thing called a meningioma. What do I go do next, doctor? What do you say? No.
I would say the next step might be surgery, right?
So no. That's a good point. She may need surgery, we don't know, but you need more information, right? So you got a CT scan, and like we talked about earlier, the CT scan is great for showing you bone and blood and some general things about the brain itself, but it's not really good at showing you the significant information about different structures in the brain that might be affected, the architecture of the brain itself, the anatomy of the brain itself. And so the thing for patients who come in with any sort of a tumor, and that's what a meningioma is a brain tumor, or a tumor of the meninges itself, is that you want to go ahead and get a scan that gives you as much information as possible so you can plan and decide if surgery is needed or not. So this is her scan, and it shows, again, let's talk about scans. So this is an MRI of the brain with and without contrast. And I'll get more into whether it's benign or malignant. That's a good question. So it's MRI of the brain, which is with and without contrast. You can tell that there's contrast because you can see the blood vessels are lighting up. There are blood vessels here. This type of an MRI is an axial cut, T1, which we won't go into. That's a longer subject on the radiology part. And this MRI here that you see is a coronal view, the one that cuts in front like this. So axial like this, sagittal in the middle, coronal in front to back or back to front. And like we talked about before, you're looking for symmetry, right? So what is normal and what's abnormal? What do you guys see?
The large white mass is definitely an issue to take care of.
Yeah, there's a big mass on the brain itself on the left side, actually. So the way we do imaging is that it's the opposite of what you see on the screen. So it's if the lesion's on the right side of the screen on that cut, then it's actually the left side of the patient's body. It's just the way you look at the patient from the feet up and not from the way your body is standing. And that puts everything on the opposite side. So this is actually the left side of the patient's brain. So you can see here, what you couldn't see on the CT scan is this architecture of the brain itself. You see the gyri, you see the sulci, which are the little pits in the brain, the sulcus that you see there. And you don't see that as well over here. And you see this big lesion over here. And you look for symmetry. And if I draw a line straight down this way, what happens? Everything's shifted over to the right side of the patient, okay? And so This is a slow growing tumor. How do I know it's slow growing? She's still neurologically doing very well. She has no major deficits. She's still very functional. She just has seizures because this is compressing her brain and interrupting the normal signaling of her neurons. And so what do we need to do about this? Do you want to send her home and say, well, let's just get another scan in about 6 months and see if this gets any bigger? Let's take it out. I want to do it tonight. Or let's take it out and we can do it in a month or so. What do you guys think? Surgery to remove it. You can always get a biopsy. That's true. Surgery in a month or so. That's absolutely correct. So when you look at meningiomas in general, they're slow growing tumors. They're benign. They're not going to cause a significant deleterious effect to the patient in the next day or so. So you don't have to rush the patient to the operating room right then and there. It's best to take it out as soon as possible, but it's not an emergency. Meningiomas that are very small, you don't actually have to take them to surgery. If they're not having any deficits from the meningioma, and even if they had some small amount of seizures and that's under control and the meningioma itself is very small, you can actually watch these for years. This tumor probably took 20 or 30 years to grow, to be honest with you. Now, I think this tumor is a little bit more invasive, which is what the pathology ended up showing afterwards. And you can tell that just based on the architecture of the tumor itself and how it is invading into the sinus, which is one of the venous structures of the brain itself that drains the blood from the brain, but also invading a little bit into the gray and the white matter there instead of just displacing it. Most meningiomas will just displace the brain itself. And until there is no more room for the brain to move, most patients remain asymptomatic. When the brain can't move anymore, that's when they start having symptoms from it. So if this was a small meningioma, I would just watch this. I would sit there and say, hey, I don't think you need surgery right now. We can wait on this and give this some time. And I've watched meningiomas I've been a resident for 4 years now, and I've watched meningiomas for 4 years and never operated on a few of these. I've had patients who have come to see me in clinic 10, 15 years down the road, and their meningioma is not growing. So going in and doing brain surgery to take it out is not the best thing for that patient. However, in her case, this is a pretty big meningioma. It looks like it's invasive, and she is having seizures, even though they are controlled by Keppra. So I kind of talked to her and I said, listen, we can take this tumor out. You've probably had this for several years now, and you're really not having any functional deficits. So if you decide that, you want to go ahead and get surgery for this, I'm more than happy to do it for you. I told her that, I don't think this is going to be a complete cure, because to completely take this tumor out, you have to invade the sinus, which is pretty anterior where this tumor is at. And the superior sagittal sinus is the main drainage pathway of the brain. And if you were to take that at such an early point, it can be pretty deleterious to the patient and lead to significant morbidity for that patient. So you always just have to counsel the patient and say, I think we can take it all out. I don't think we can take it all out. I think we can get you the relief that you need. I think we can get the pathology with a biopsy and see what's growing and go from there. So the role for surgery here is to get pathology, figure out that this is for sure a meningioma, relieve the pressure on the brain, and take out as much tumor as possible to give this lady the longest life that she can get. So we did what we call a frontal craniotomy for tumor resection. There's myself over there with my loops on. And this is my junior resident, Dr. Hugh, assistant in the case. And if you look over here, you can see this almost golf ball sized tumor that is well encapsulated, kind of just rolling out, took out in one piece. She did very well. She had what we call a World Health Organization grade 2 meningioma, so a little bit more invasive. It's still benign, it's not malignant, but it's kind of getting towards that malignant portion. On her immediate post-op examination, she woke up with what we'll call SMA syndrome, supplementary motor area syndrome, because that tumor was invading the supplementary motor area. And so when we took that out, we stirred up some edema or swelling in that area. And she woke up with some weakness on her right side where she couldn't really move her hand as well. And so that typically resolves on its own within about 2 to 4 weeks, but it can take up to a few months for it to go away. And at 1 month, she was back to full strength, walking on her own without a walker and doing very well. So you always have to weigh the pros and the cons of taking some of this surgery. Any questions about that case? Cool. Let's talk robots. I love robots. All right, you can tell the nerd in me is coming out. Oh, I forgot to tell you guys a joke. Dang it. We'll get back to it. I'll tell you guys a funny joke. So robotic spine. We have a 67-year-old male, 2 years of just excruciating pain in his right lower extremity. He's got numbness and tingling in what we call an L4, L5, and S1 distribution. And I'll show you a picture of what that actually means. But he's also got excruciating low back pain. He's full strength on examination. So again, it's that trend. You get the history and you go do a physical exam. He's full strength in all 4 extremities on examination, but he does have some just decreased sensation to light touch on the right side. He doesn't have on the left side. He can feel everything just fine on the left side, but the right side, there's just something off. So we do a test called an EMG, where we look at the conduction and the functionality of the nerves. And they confirm what we call an L4, L5, and S1 radiculopathy. Does anybody know what that is at all? Just throwing crazy words out that don't make any sense. So a radiculopathy is a disorder of the nerve root itself. So the nerves are going to travel out of the spine. I'll show you guys an image of that. From the spinal cord, the nerves travel down, and then when it gets to the conus, which typically is around T12, L1, T11 in some patients, you get what we call the cauda equina, which are the horse's tail in Latin, and those are just the nerve roots that kind of dangle down and travel down the rest of the lumbar spine and then exit out the foramen and go down our lower extremities to give us a motor function, sensation, and sensation as well. So now that this patient's told you their life story, what do you want to do next? What's the theme of today's talk? You want to get some sort of imaging, right? You want to see what's going on. Yeah, you can try to get a brain scan. That's true. That's one thing you can think about is where is this coming from? So if it is something central, so in the central nervous system itself, the brain, then an MRI would be appropriate. But this patient didn't really have any central nervous system signs on exam. They just had some decreased sensation, some numbness in their legs, and it seems to be coming from a nerve root itself. So you don't have to chase it all the way up to the brain. You can actually just do a focal MRI of the lumbar spine itself and look at those nerve roots and see if there's anything going on with those nerve roots, if the signaling is being interrupted distally, which is where those nerve roots are coming out, and not centrally. So sort of peripherally. So let's take a look at what that showed. So before we jump into that, so these are the dermatomes where those nerve roots are going to run into. And this patient is complaining of L4, L5, S1, numbness, tingling, and pain. And it's kind of traveling this band-like pattern where those nerves themselves are traveling before they split off into their into other nerves there, their branches there. So when I see a patient, I try to really just localize where these symptoms are coming from, because if I can localize it, then that tells me the test to do, and I don't have to do a test of every single part of the body. So because of this and what I saw on examination, I went ahead and got an MRI of the lumbar spine. So let's go through it really quickly here. Cool. So that's an MRI of the lumbar spine. So let's just go through a few things really quickly. So again, when you're seeing scans, how do we talk about scans as physicians? What's the first thing you want to know? Or I want to know when I'm asking you those questions. What kind of scan is it, right? So it's an MRI. What's the location of it? The lumbar spine. And what kind of view are you looking at? It's a sagittal view. So it's cut like this. So in this scan, you can see the vertebral bodies, which are the blocks of bone that sit on top of each other. And in between each vertebral body is an intervertebral disc, which is this dark gray substance that you see here. Now, these should be nice and plump. They shouldn't be flattened out like this is. They shouldn't be herniating into the vertebral body, and that's what we call a Schmorl's node, which is one of my favorite words to say. And they should look basically like boxes. They shouldn't look scalloped like this. And when you see things like this, it tells you that there's degeneration in the spine. So this is a degenerated spine. And I'm trying to get a good cut here. Perfect. Do you see these wispy tendrils coming down? Those are those nerve roots. That's called the cauda equina. And the white that you see here, that's spinal fluid. It goes up and down the spine, cushions the nerves, provides nutrients to the nerves, helps to remove waste from the nerves, does quite a bit. Now, if you look up here, if you look back here, these are the spinous processes. So if you feel at the back of your neck, you will feel these little bumps at the back of your neck that are bony, and those bony prominences go all the way down to your lumbar spine, and those are called the spinous processes. In addition to that, what I look for when I look at these scans, I look at the discs, how they look. I look at the thecal sac, which has the spinal fluid in it with the nerves. And I want to see that it's nice and wide open like this, right? So this is wide open. There's nothing compressing the nerves. It doesn't look like it's under pressure. But when you come down here, you start seeing that there's something impinging on the nerves over here and over here. And over here as well, right? There's something going on that's just a little bit different. So then I look at the nerves themselves and how they look as they're exiting out. And you can see that the nerves are being compressed in their foramen where they're traveling to. And it gets pretty tight as they travel in and out. And you can see that this nerve is compressed there. That one's a little bit open, and so on and so forth, right? And so you tailor your imaging technique to the presentation of the patient and where you think things are coming from. So if you think things are coming from centrally, then I'm not going to get an MRI of the lumbar spine. I'm going to go get an MRI of the brain itself or the spinal cord. But if I think things are coming a little further down, like over here, based on the fact that the patient doesn't have any significant weakness in their upper extremities, and it's all just lower extremity based, and they also have just numbness and tingling, which is pretty nonspecific. But if it's running in a specific pattern of a nerve, as that nerve travels anatomically, and that tells me exactly where I need to look at, which is where that nerve is running from. So I want to know where that nerve is coming from, and I look at the MRI of the lumbar spine to let me know exactly where there is compression in the spine. So now that you've got the MRI of the lumbar spine, you see that the L4 nerve root's compressed, the L5 nerve root's compressed, S1 nerve root has some impingement on it. You're thinking to yourself, well, L3 also has something there. What do you want to do? Do you want to say, all right, well, sir, I know you're in pain. You have low back pain. You also have some nerve, some dysfunction of the nerves themselves as seen on the MRI, your physical examination, and the EMG. So you have three things telling you there's something going on. Do you want to offer them surgery? Do you want to send them home and say, let's do conservative management for you? Or do you want to just kind of keep bringing them back to your clinic for follow-up? What are you guys thinking?
Maybe send them back to the clinic for a follow-up.
Good answer. So that is exactly what we did until I said he needed surgery. So you want more information, right? And unfortunately, I don't have this for you. So what I did for this gentleman was I told him, I was like, listen, your nerves are compressed. There's several other things that we need to do before we get to surgery, right? This is the decision-making factor that Cushing was talking about, where, Cushing was talking about that, not everything needs to be rushed to the operating room to be operated on. Things will need to be operated on, but not everything does. So I sent this patient for injections of their back to localize exactly where the symptoms were coming from, to numb the nerves. And when the patient had complete relief of all their symptoms with that, it lasted about a month. Then I brought them back to our clinic. I said, how'd that feel? It felt good. Do you want surgery? Patient's like, yes, I want surgery. Well, I say surgery is indicated, but we need to do a few things to determine what the best surgery is for you. There are patients who, with this scan, do not want any surgery at all. And so my job as the surgeon is not to force them to get surgery. My job as a surgeon is to give them the options for treatment of their ailment to best treat them. And so some of these patients may do just fine with some conservative management. Now, conservative management doesn't fix the anatomical pathology that you see there. So that compression needs to go for them to get complete symptomatic relief or the best relief that they could possibly get for their ailment. And so in some patients, I'll send them to go get injections for months before they'll come back to me and say, well, the injections aren't lasting as long as possible now. Can I get surgery? And I'll say, sure, we'll go ahead and do it. And some patients are like, I'm ready to get this taken care of right now. Let's go to surgery. There are other tests that you want to do to determine the best type of surgical approach. One of those tests is get some x-rays where the patient bends forwards and bends backwards. The reason why you do that, and unfortunately I don't have the pictures for you, is that when you bend forward and bend backwards, your spine should move together with you. It should move like this and like that, flowing with each other. Well, if your spine is doing this, going back and forth, you're just banging on those nerve roots every single time that you bend forward and bend backwards, every time you take a step, and then you start having that shooting pain coming down your leg and that distribution where those nerves are impinged. And so I made him get that, and sure enough, he had some micromotion instability in his spine. And based on that, I recommended he get a spine fusion to stabilize his spine and decompress the nerves. So here we are in the operating room, and this is one of my other cases that I did with that. And what we have here is my buddy Rex. Rex is the robot, the spine robot over here. And what we're doing is we're putting screws into the spine itself, and I'll show you a picture of that. And we're taking off the bone. Let's go back here so you can see it. Oops. And so what we're doing is, boom. We're taking off all of this bone to decompress the nerves, and we're putting screws in here to hold everything in place. And we're doing it at multiple levels and linking those up with rods, which you'll see shortly. And so this is me hanging out with my buddy Rex, and we're putting screws into a patient with robotic navigation. So in this case, you're just using a CT scan that's done intraoperative to get kind of real-time navigation so you can see where your screws are going virtually into the patient's spine. And the robot's there just kind of hold things in place for you as you place your screws. And then you move the robot out of the way when you're done, okay? So neurosurgery involves a lot of technology. So if you're interested in technology, this is the field for you. I love the robot. And then when you're done, you get x-rays to see what it looks like. So we've taken off all this bone that was there before. We've put screws and hardware into the spine. We've decompressed where those nerves are exiting out of. And we've put what we call interbody cages in there to help elevate the foramen where the nerves are traveling out to remove the compression from the nerves themselves. And so that's the surgery this patient got. And let's see how they did. So post-op, remained full strength, spent about 4 days in the hospital, discharged home, and in 1 month follow-up, he had complete resolution of his right lower extremity pain and tingling, but his numbness was sort of improved, but not completely resolved. And that's what we see in a lot of patients. Their pain gets better, their weakness gets better, the tingling gets better, but the numbness is the one thing that just stays for a while and can take up to a year to go away. And in some patients, it just doesn't go away. The nerves don't heal up as nicely as the rest of the human body. So in conclusion, these are the bread and butter cases of neurosurgery. Even though to me, these are typical and technically routine cases, I do those TLIF, transforaminal lumbar antibody fusions, probably 2 or 3 times a week. Take a brain tumor out every couple months or so at the VA hospital that I'm at right now. And then at the other hospitals, they're doing it basically at least once a week or once every couple of weeks. They're taking out tumors of the brain. We're doing decompressive craniotomies. Once trauma season hits, it's a routine nightly thing. And so it gets to the point where you just do these cases, you come in and you just boss through them and do them. And they may seem technically routine, but They're still exciting to me. I love talking about them. I love doing them. I love teaching our junior residents here how to do these cases. But to our patients, they're nothing. They're not routine. This is a field that greatly impacts patient lives and also family members as well. And on that note, thank you very much. These are some of the people on my team. That's Dr. Hugh, closing up for me after a case as one of our nurse practitioners, with Dr. Hugh as well. This is Dr. Budnick. On her last day, her last case, I think we were doing a brain tumor resection that day. And this is me riding Starlight, one of my favorite horses. And then lastly, I keep forgetting to tell you guys this joke because I thought I was going to tell at the beginning, but I totally forgot. But what do you tell the patient right before you put their skull back on? All right, I'll tell you. They're not going to be open-minded anymore. All right, on that note, I'm going to open up to questions. Please feel free to ask me any questions about neurosurgery or about any of these cases, and we'll go over.
I had one question with patient interaction.
Yeah.
Like, so you said that you try and not make surgery the end goal for a lot of patients, but I was wondering, like, if a patient really insists on getting surgery, what do you do in that situation?
That's a very good question. The first thing that you do is you never get bullied into doing a surgery that you don't want to do. At the end of the day, you are the surgeon, you are the expert, right? You've gone through your training and you do know what's good for the patient and what's not good for the patient. And I've had patients who I've told, I'm not going to operate on you under any circumstances because you don't need surgery. Surgery is not going to fix this, and surgery could potentially make things even worse. And those patients have gone out to other doctors who have said, sure, I'll do it. I'll take care of you, and I'll take care of whatever you tell me to do. And they'll do those surgeries. And, you know, some people get away with it. The majority of them don't, because they'll come back and see me with these crazy surgeries that have been done elsewhere with no benefit, and they're in more pain and more debilitated than they were before. A great example of this is laser spine surgery. Nobody does that anymore, and it was a thing in the neurosurgery community where we were all warning people about laser spine surgery because most of those patients really didn't do any better. And so patients would go get laser spine surgery done and come back with worsening pain because the anatomical pathology was not treated adequately. So you never get bullied into doing something that you don't want to do, right? This is your specialty and you are the surgeon. So you give the patient the advice that you can. And if they don't want to take it, then it's okay for them not to take it. That's one of the things that you'll learn as you go along. It took me a while to learn that, as from an intern to now. I'm now more comfortable with saying no to patients than I was as an intern. Somebody asked, what are some classes I could take during the rest of high school to prepare for university and med school? That's a very good question. You know, I think getting a broad education is very important. I took in high school, I mean, you have to take your sciences, obviously, like your classes are basically handed to you as to what you need to do. But once you get to university, you have to go through the pre-med track for the most part, and those courses are pretty much tailored to physics, chemistry, biology. But I would actually recommend doing something else in the arts as well. I took an anthropology course in high school, in college and university that has impacted me the rest of my life. I took a ceramics arts course in college and university that I still do on my free time, go and do ceramics for fun. I took a literature class in high school that I still remember the books that I read in that class, and I still discuss that with people. And it helps you have these experiences outside of the sciences that I think really patients love to hear that and love to have a physician who, you know, understands them as a human being. And I think those arts classes will really help you with that. But the biggest thing is you got to do well in those courses. And the best way to do well in those courses is to learn how to study early on. So if you're in high school, in grade 9, you gotta learn how to study now so you can apply those tricks when you get to college. And also, you don't have to decide on being a doctor at grade 9. I was going to be a chef, so it's a big turnaround. What was the hardest thing that you remember in med school? Oh man. I think studying for my USMLE step 1, and then the first day on rotations as a med student. So your first years of med school are spent in the classes where you're learning everything basic science, and your last years of med school are spent in the hospital where you're applying those basic science principles to patients. And so between your second year and your third year of med school, you have to take the national board examination, USMLE step 1. And I knew I wanted to do neurosurgery, so I knew I had to study hard and get a good score on that. So that was very stressful, but I got through it. And the main way I got through it was through my friends. We all studied together. We hung out together. We a very close-knit medical school group. In fact, I was on a phone call with one of my closest friends, Kaylee, who just had a baby recently, and she's doing her residency in neurology in Chicago, and we just chatted. And so we've kept in contact for so long. And that's your support group. You'll find your family in med school and in residency as well. And then first day of rotations, you're actually with a live patient. You actually have to go in and interact with another human being and not a textbook. And so it's a little nerve-wracking trying to remember your examination and talking to a patient. But again, if you have your support group around you, you're going to do just fine. What made you get set on medicine rather than other career paths? That's also a very good question. So the reason I chose medicine is because I love the science behind it. I love the interaction with patients, and the only field that you really get to interact with human beings and apply science to is medicine, right? You take the stuff that you learn in the basic science lab, you bring it into the hospital, and you treat patients and try to get them to feel better. It sounds cliche, but I want to make people feel better and treat patients. So that's really what set me on medicine rather than becoming a chef. I still love cooking, but someday I'll hopefully own my own restaurant. But until then, I love coming in and helping people as best as I can. Somebody asked, what qualities do you think are important for being a neurosurgeon? There are several qualities that are very important for being a neurosurgeon. The biggest quality is honesty. And this is something that permeates through anything that you do. Is you gotta be honest. You have to be honest with yourself. You have to be honest with your colleagues. You have to be honest with your patients. You have to be honest with everybody. You don't want to lie to people. And so honesty is a big thing because your integrity in this field is very important. Other qualities are you have to be hardworking. This is not an easy field to go into. This is not a field that you're going to go into work at like 9 a.m. and come home at like 2 or 3 p.m. It's a field where you're going to be grinding for 7 years, and you gotta put in the work to get to that point, and then grind for a full 7 years, and then some after that if you decide to do a fellowship. So you have to be hardworking, and you have to care about patients. That's really another big quality that I look for in our applicants that come in for residency here. People who care about patients, it really shows. And you'll see that as you go through the physicians you interact with and the healthcare professionals that you interact with. The ones that you love the most are the ones that you can tell really do care about their patients. What kind of hours do I work now? That's a good question. If you had asked me that a couple of years ago, I'd say that I was working pretty close to 80 hours a week. Now I'm probably working about 60 hours a week, sometimes 80 hours, depending on how call is. The ACGME, which is the accrediting body for graduate medical education, has a mandate that you can't work more than 80 hours a week, okay, in residency. Neurosurgery is one of those fields where you are getting right up to those 80 hours a week, especially as a junior resident. So you will be working quite a lot in this field, but it gets better as you go along. Now that I'm chief at the VA hospital, and when I was chief at Eskenazi, my days are very different than when I was a junior resident in the hospital all the time. So there's a big difference as you graduate through the residency program. Let's see. What are your study tips? That's a very good question. So study tips. So I like to read things once over, just sit there and read it like I'm reading a book. Then I like to go back and just take notes on what I've read and just try to find the most important keywords that I can find. And then after that, I will take the weekend to just review. That's my studying habit. I like to listen to podcasts or listen to lectures if possible, because it gets after a while, you just get tired of reading, I like to write things down or type them up and save them in a document. So I use Evernote a lot. Not promoting a product here, but Evernote is fantastic for notes. I love it. And I will send my junior residents for every case that I do. I go back and I write down every single step of that case, and it just ingrains it in your head. And when I became chief, and my junior resident will come up to me and say, "Hey, we've got this guy in the ER, needs to go to OR." I'm like, "All right, sign him up. Let's take him to the operating room. We'll go to the operating room." And then my junior resident goes through and does the case. And I'm telling them every step they need to do. And before the case even starts, I will send them that document with every single step so they know what to do when they get to the operating room. And I watch them and I help them and I teach them how to do it. And the only way that you can get to that point is if you actually know every step and you write it down and just go through the motions over and over again. So repetition is key. Writing things down is key. Reading and reviewing is key to studying, and setting up a study schedule is so important. Have you accessed the lateral ventricle through Tubbs point on a living patient, and how was the experience? I've not done Tubbs point. I've done Fraser's point, Keene's point, and so there are several ways to access the lateral ventricle. The easiest way to access the lateral ventricle is to go 10 or 11 centimeters back from the nasion or the glabella, and then 3 centimeters lateral. Either right or left. If you drill perpendicular to the skull and aim your ventricular catheter for the medial epicanthal fold and for the external auditory canal into a line that kind of runs in between each one, then you will be able to get into the ventricle every time without a problem. And it also depends on what procedure you're doing. If you're doing a procedure where the patient is prone and they're laying down, it's going to be really hard to access the ventricle that way. So you go through a different point in the head. If you're doing it with their supine, then you can easily do that point as well. Is it true that every doctor has a lawyer friend and knows a lawyer? I don't know if that's true or not. I have lawyer friends that are just friends, and I hang out with them on the weekends. I hung out with one of my lawyer friends this past weekend. He doesn't do medical law at all. He does like criminal law. So, doctors just have friends. It doesn't matter whether they're lawyers or not. How do you maintain your motivation, prevent burnout? That's a tough one. I love what I do, so that helps me maintain my motivation. I love working with my junior residents. That helps me maintain my motivation. I love learning about everything that I do, so that helps me continue to maintain my motivation. I prevent burnout by the people I surround myself with, ensuring that I'm not just focused on my work 100% of the time. So that's how I do it, and that's what I recommend for everybody to do. All right, I think that was the last question. Does anybody have anything else?
No, I don't think so. And as we end this meeting, I just wanted to say thank you so much for your time. I'm going to leave your Instagram and our Instagram and contact information in chat. And then we will be emailing you guys, or like everyone that's signed up, a recording of this as well. And we'll be posting this on YouTube and our website and other stuff. I want to say thank you again for everyone for coming, and especially Thank you, doctor, so much for your time.
Not